to attend this emergency pediatric session, and yeah, I realized that a few of you came after a night, so on call. So I will be quick and concise. Basically, this presentation is supposed to be interactive presentation, but because of the way we live nowadays, we will do it like this. And if you have any question, or if you have an experience you would like to share, just write in the chat box, and then we will discuss it further. Emergency pediatrics, obviously, to the people who haven't worked in pediatric, this is like scary, and this is the way we look, basically, like this child whenever we hear an emergency. Okay, what is that? That the right time, what I'm supposed to do. And this is why we went into this ABC approach in managing all the emergency situations in pediatrics and adults. And when you look like this, then remember that if you go ABC, you will never go wrong. And the emergency pediatrics is a wide topic, and I have chosen 6 or 7 emergency scenarios. We'll go through them, and then if you have any question, please step in and ask the question. Obviously, it's ABC, so I will start with airway problems. Like this girl, for example, when you working with us pediatrics, and you come across this scenario, 4 years old girl or boy, obviously, and then come to the emergency pediatric because vomiting and persistent cough. The relevant piece of history in this scenario is the sudden onset. This means while playing. This means that this child was healthy before, yeah, and then she started to have some sore throat, and her voice changed, and the coughing increased, and followed by retching, and she's not getting better. And but otherwise fit and well, and the past history is fine, and her observations are fine. Let me get this screen. Anything anyone can write about what the diagnosis is? Right or wrong, it doesn't matter. If you write quickly. Okay, I haven't got any responses from you now, so I will move on and say, okay. In a situation like this, you have to ask yourself, okay, this child sudden onset, what is likely to happen? This means something to do with sudden onset, like upper airway obstruction of sudden onset. The most likely diagnosis here is from body, because infection starts with fever and being unwell, and then anaphylaxis, sudden, but there is a history of allergy to anything, and then coma, obviously, or be comatose. Edema, if the child has been exposed to smoke or something to irritate the upper airway. And to assess this child, we don't usually come near to the child unless we build a rapport with this child, because being in the hospital, seeing strange people in a strange environment to the child is scary. So if you see a child sitting with the mother's lap or holding to their mother, don't disturb them. Just use your eyes and your ears. You will get loads of information from doing this. Yeah. So, for example, breathing. Yes, you can look at this. Is the child conscious? Is in distress? Is any secretions coming out of the mouth? How is the breathing working? Yeah. And the listening, use your striders. It will be quite obvious. And then if you come nearer and you see that air coming in and out of the mouth, or the child is like sitting, like breathing normally, this would be a lot of information here to give you information about the airway. I don't want you to, in any situation for assessing the airway, to do this like airway maneuvers, because these are done in children who are unconscious and drowsy. Yeah, and if you come across this scenario, child with upper airway problem, unconscious, drowsy, yes, you need to work on the upper airway. You need to open the airway. If they are less than a year, you put them in the neutral position. If they are more than a year, you put them in the sniffing position, head tilt, chin lift. Obviously, when you are doing this, you'll have a chance to look at the mouth, and if there is any secretions or any thing you would like to remove, then use suction, but be gentle in the suctioning, because you can easily make things worse by doing vigorous suctioning and then the child starts to vomit, or you stimulate the vagus through like the voice box, and then you end up having bradycardia and things go in the wrong way. If the child really comatose, then the airway, you would like it to be open, then you can use one of these gadgets and from the oral airway or the nasal airway. Yeah, the way you obviously you will not use the nasal airway if the child sustained head trauma, because you don't want to do this when there is skull base fracture. Yeah, you size them the right way from the central incisors to the side of the jaw if it's the oral one, and then from the nose to the tragus of the ear if it is nasal, and then you use this bag to deliver oxygen. But guys, these maneuvers are in the children who are not conscious. If you put these in a child who is conscious, then cough, 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 and then you will get into troubles. Always when you support the airway or open the airway, be conscious of the C-spine, right? And if you are suspecting C-spine impairment, you have to support it by manual inline stabilization or using blankets or blocks and tape. Yeah, we have shied away from the collars because they cause the more troubles than benefit, and they are history now. So I'm not going to talk about them. Use your hands the way you see in the picture to support the spine. Okay, now back to this girl. With this history, do you need to do an X-ray? Let me see yes or no on the chat box. Do you need to do a chest X-ray for a child who is presented like this and the vomiting and the coughing cause of foreign body? Yes or no? Any chat box, guys? Laura, Steven, wake up. No? I forgot the name of Vicky. Just yes or no. Do you need to do a chest X-ray? No, as there is a clear cause. Well done, Stephen. You have had a strong cup of coffee, Stephen, to answer this question. Yes, there is no need for this, guys, because basically a foreign body, you need to get the foreign body out. And we will see how we get the foreign body out. And this is by encouraging the child to cough and giving him back blows. Right, but we did the X-ray, right, and we saw this foreign body, and it sounds like to be a battery, right? That's fine. We need someone who has the skills to remove it, whether to go in the T, whether to go gastroenterology. This is something you can sort out of the day, but if it is in the esophagus, this is gastroenterology. If it is above the voice box, it's likely to be in the T, and you are waiting for them to come, and until then things went badly and the child started to cough. Now coughing continuously, and as I say, we should have done this from the outset. before even considering the X-ray. 5 back blows if they don't pass the object, then 5 chest thrusts and alternate until this foreign body comes out or vomited, or the child then gets tired and exhausted, and we'll see what we can do in this scenario. You can see that children who are easily to carry, you can do this on your lap, right? But if they are older, like the one sitting in the second picture, then you can do this while they're sitting, better when they are standing, right? And if they are older, like 10 or 11 or 12, they can give them abdominal thrust instead of chest thrust. Is that all right, guys? And then things went worse, and then become unconscious, and then what now? Okay, what now? Is there any answer here? What now? Quickly, 3 letters. If what now? Yeah, anybody can give me 3 letters? What now? No? Shall I move on? I'm waiting. Stephen, Laura, Vicky, CPR. Yes, 3 letters. Yeah. Okay, now we have to do CPR because the child now is unconscious, yeah? But look, listen, and feel, and then if open the airway and start CPR until help arrives. And this cartoon tells you where to go, foreign body, assess severity, child is coughing, i.e. green, courage to cough, continue to check for deterioration to an effective cough or until obstruction relief. But if the scenario starts with ineffective cough, then you say, okay, is he conscious? Yes, he's conscious. Yeah. Back blow, 5 thrust or abdominal thrust, as we said, and be conscious if they are of small size, because you don't want to traumatize the liver or the spleen. And if they are conscious, then open airway, 5 breath, and start CPR. Okay. Any question, guys, about this scenario? Because this scenario you can easily come across anywhere, not only in the hospital, but in the community. Any questions? I'm looking for the chat box. Good so far. Thank you very much. What's your name? Stephen again. Okay. Thank you, Stephen. I will move on then. Okay. The second scenario I thought I would go through is one again, which you can come across in the hospital or in the community, and because I thought like calling this slide the wrong cake, but because I love cake, I said, okay, let us go for the love cake. This is a girl who went to this friend's house for birthday party, and then after eating the cake, she started to feel unwell and noisy breathing and rash. And then when you examined her, very anxious and the generalized urticaria rash, swollen lips, abdominal pain, diarrhea, and there is audible stridor. I just wanted to you to write good or bad. Just write good or bad. Any chat, guys? Good or bad? The scenario here. Bad. Stephen is like. Are the others joining us, or they have left, Stephen? We don't know. Okay, so this is bad. The bad thing about this, guys, is like, where is my presentation now? Okay, I think I might have done something wrong here. Okay, yes, I've got my presentation back, but I can't see the presentation. Yes, I see them now. The reason it is bad because of this stridor. Then there is an upper airway obstruction. Here we have to deal with it, but we have to think about, okay, this is something anaphylaxis. This means that this is vasodilatation, and this means that this child needs support. Obviously, as we said, we'll go A, B, C, D, E. And the easy thing here is all of us think about adrenaline, which yes, go ahead, right? Go ahead and give adrenaline, but at the same time, you have to think about the airway stridor, so give oxygen, yeah? And it doesn't have to be like oxygen on the face with a mask and the scary stuff. You can give oxygen with as long as the saturation is maintained, right? And then you have to think of the circulation. This child has vasodilated vessels, so he might have hypotension. So this child lie the patient flat and raise the legs. Yeah, this is very important. You can do this until you prepare the adrenaline. Once you give the adrenaline, things will get moving. But the oxygen, and if you can give IV fluids, that's fine. You put the ECG, you put the pulse oximetry, you measure the blood pressure, and they carry on, right? Obviously, there are adrenaline doses for the children, like less than 6 years, 60, which will be 150 microgram, the 6 to 12, 300, and then from 12 to adults will be 500. But not all the anaphylaxis is like managed like this. Sometimes you come across similar scenario when the child comes with just arterial rash. There is no swollen lips, there is no stridor. So this is peritone and observe, yeah? And there are other scenarios when you give the adrenaline and then it doesn't work, another adrenaline, and if it doesn't work, another adrenaline. And then you find yourself, okay, now how long I'm going to give this? Then this is where the IV fluids and hydrocortisone will come handy. Is that okay? And any questions, guys? How many doses can we give? Yes, this is Vicky has asked how many doses can we give. You can repeat this as long as the child is still symptomatic. And obviously, as I said, if you give the first dose and second dose, and then on the verge of the third dose, then you'll have asked for help, and this is where the other resuscitation team will come. One will put the IV line, one will give like a bolus of fluid, the other one is preparing the hydrocortisone and giving it, yeah? But if you give the first dose of adrenaline, basically, and the child is still symptomatic, this means that hasn't worked. But you have to go through the ABCD again. Like, for example, go back, is the airway open, give oxygen. Yeah, does this answer your question, Vicky? Yeah, thank you. Okay, and right, okay. I will move then into another scenario. We have mentioned a couple of scenarios now about the airway. Now the lungs here could be asthma, could be pneumonia, could be pneumothorax, could be like a pleural effusion. So many cases, but I chose asthma because this is most likely the scenario you will meet more frequently than others. And this boy, there isn't anything tricky about him. He is not asthmatic, and he is on high dose of like steroid, and he is on salbutamol, and he's on oral. So he is on the whole lot, oral therapy. And when he comes to the hospital after ICU admission, he responds to aminophylline. So the diagnosis is clear, the severity is clear, but or the past history of the severity is clear. But when he comes this time, his respiratory rate is 32, his heart rate 150, his oxygen saturation is 19 air, and decreased air entry on both sides. Good or bad? This is Charlotte bad. Yes, you are right. You are absolutely right. So if it is bad, if it is that bad, and Laura as well is saying very bad, and you have to do something. From the severity here, you have this chart which I don't think you can see it properly because I can't even like read it with my glasses on. But this is like the EPLS or EPALS sort of classification: moderate, acute, severe, and life-threatening. And this child, this situation, he falls under the life-threatening. The life-threatening here means that we will bombard him with all the medications we know, and starting from the airway, we'll give oxygen, we'll give salbutamol, puffs, and then it doesn't work, we go for the nebulizers, and every 20-30 minutes, the ipratropium, every 6 hours, oral prednisolone, opposite doesn't work, he's severely ill, then we go to IV hydrocortisone, again, still working hard, give IV magnesium, oh my God, he's still like working hard, give IV salbutamol bolus and then infusion, or if you are familiar, give aminophylline. And the child response is not that great. And clinically, basically, clinically, you standing there next to this child, you have to ask your question. Am I winning here? Obviously not. When I'm going to move, right? And when you are going to move, okay, tell me then, we need to progress here actually, guys. Am I supposed to do a chest x-ray for this child? Yes or no? This question to all of you. Do I need a chest x-ray here? No. Well done, Vicky. No, 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 right? There's no chest x-ray. Do I need to, like, what should I assess here, right? And yes, Stephen said, if the child presents with a moderate severe asthma exacerbation, accident emergency, and uh, and they respond well, observation normal, etc. I can't see more than this, see more, okay, and or can be safely netted and sent home if the social circumstances allow. But do they still require admission or can be safely? Basically, in a scenario, yeah, thank you very much. This is like what you do for children who are responding, but this child is not for home. I think this child, we need to find out clinically, because we have done everything. We need to know, is he getting tired? The air entry is poor on both sides, saturation is not good, and the blood gas here will come handy, because if the blood gas shows you a normal PCO2, now you know that this is bad situation. If the blood gas shows you that the PCO2 is higher than normal, then you know that it is like worse, right? So, and you can here take a decision to intubate this child clinically, right? If the child is getting fatigued, if he's unable to speak or shorten the sentences, poor air entry, or absent wheeze. Absent wheeze is not reassuring, guys. This means that the child is very, very tired. Yeah, and so that the wheeze is not even audible because there is no effort to get the air in. Saturation is low, and the PCO2 is normal or high. This child is going for intubation, and there is no other options, because if you wait more than this, then the child will go into cardiopulmonary resuscitation. Guys, I would like to, before I move, do you have any question about this? Because this is very important, especially the blood gas and its interpretation in asthma. the normal, or not the normal, the expected blood gas of a child who has asthma or presenting with acute exacerbation of asthma is low PCO2. And this is because they are washing the PCO2 out. So because they have prolonged expiration. Does this make sense? I think your answers will be yes. So it is normal PCO2. If you find that the PCO2 in the blood gas of a child who is presenting with acute exacerbation of asthma, normal PCO2, this means that the child is retaining the carbon dioxide. This means the child is tired. This means that the child cannot wash away the PCO2. And this is mean that the child is going in the wrong way. This means that he needs more attention. This means that you need to call the anesthetist or at least help from your registrars or consultant. Is that all right, guys? Say yes or no. Or if you have any questions, please. Yeah, I'm waiting for you quickly. Vicky, yes. Okay, yeah, that's good. And Laura's saying yes. So they all agree, and Stephen agree with me. That's good. We are on the same wavelength, guys. And this will be it regarding the asthma. Manage the asthma. Look for these clinical signs of deterioration and call for help early. Yeah. Okay. I'll move to another scenario, and this is like we're moving into C now, right? So where the 5-year-old boy collapsed at home. Well, it happens for all different reasons. While he was playing with his sister, he collapsed, and then he was blue lighted to the emergency department. And then you notice a sternotomy scar. Yeah? And the parents are not here to give you like a clue what happened. And obviously I gave you a clue that this is cardiovascular, so you know that the child has a heart problem. From the sternotomy scar, he had open heart surgery, so you know that this child, when they collapse, has a rhythm problem. Yeah, so you go through the advanced life support rhythm for children with abnormal rhythm. Yeah, then this is the algorithm, and this actually looks complicated, but again, if you go into a child who has collapsed and the pathology probably heart, where would you start? I would like you to say anywhere to tell me where would you start with this scenario. So this child who has a heart problem, heart operation, and collapsed. Where would you start? Anything, even if it is wrong, I don't mind, because we are talking about something. I will go through it together. Where would you start your resuscitation? Laura, Vicky, Stephen, B, C, D, E. Well done. So you will start with the A. Exactly. Treat first what kills first. If the child has like obstructed airway, then you need to deal with this before you move on. So the A, B, C, D, and you open the airway, you give oxygen, and you start the CPR. During, obviously, you give the 5 initial breath, and then you start the CPRs 15 to 2. And obviously, you call for the help and the rest of it, and the team will come. And then you assess the rhythm. I will show you different rhythms later, but let us have an idea where would we go. When you assess the rhythm, as I will show you later, right, you will find 2 types of rhythm. Either this child has like asystole or PEA, or the child has bizarre abnormal sort of rhythm. Yeah, The one which systole or paroxysmal electrical activities, this is they need CPR and adrenaline. So they don't need anything apart from this. And the other one, which is bizarre sort of waves, whether it is like narrow or wide, they need shocks. Is that all right? You manage each scenario as you see it, but while you are managing it, you need to think of, okay, what is causing this? It's like 4 H's and 4 T's. And the 4 H's and T's are there, like the hypoxia, hypotension, the hypokalemia, hyperkalemia, and hypothermia, and the tensions like tension pneumothorax, toxins, cardiac tamponade, or thromboembolism. And then we will talk about the other, what you do during the CPR of giving the adrenaline every third cycle, and consider the IV fluids, and consider other medications according to the rhythm. Yeah, are you happy with that? Yeah, there isn't. It is. You'll find this algorithm everywhere in the accident emergency rooms, and we'll go through different scenarios now. I thought I would. This is like the cardiac arrest. This heart is like a systole. There is the first one, which is just a straight line. This is a systole. This is the dead child. Yes. Yeah. Because there is no activities, but you have to be careful here because you can easily get this in a child who is fine, heart beating, because the equipment are faulty. So when you see this rhythm, don't react until you check the pulse of the child. Yeah, obviously if they check the pulse and you find that there is a pulse, that's you know that this is faulty equipment. Is that right, guys? Yeah. So the first one, although it is like of a dead child, but it could be due to faulty equipment. Check the pulse. The second one is like bradycardia, slow heart, right? And this has different causes as we will come later on. But I'm showing you this with the third sort of ECG to tell you the difference. This one is bradycardia, and this one of paroxysmal like electrical activities. What is the difference between the two? Write anything, right or wrong, it doesn't matter, but just write anything. What is the difference between these two ECGs? They look exactly the same, as if they are copies. Yeah? Any difference between the two? Vicky, Stephen, Laura, Charlotte. Okay. Shall I take this that I don't know and move on? Yeah. Okay. Right. I'll take this like I don't know, or yeah, just move on. Basically, the difference between this one and this one is this one, the bradycardia, the child has a pulse. This one, child does not have a pulse. Yeah, and you can easily get this. And when you look at it, the child is alive. No, the child does not have a pulse. So always check the pulse. Always concentrate on the child. Don't get stuck to the machine. The machine is like equipment, electricals, anything can go wrong. It can give you the flat line, can give you this when the child has a pulse. Yeah, so don't do anything unless you feel the pulse. Right, so bradycardia could be, this is the most common cause, like hypoxia, ischemia, vagal stimulation. But when you see it in a scenario in a very ill child, then it's a peri-arrest. If you don't do anything, then the child will will go into arrest. So this is why we don't like bradycardias in the children who come to the emergency department. The vagal stimulation, most of them are iatrogenic. We do it. We do vigorous suctioning, and then we get vigorous stimulation of the bradycardia. The ischemia and the hypoxia are the most causes. So, and once you give oxygen or give some fluids, you'll find that the heart is racing. Is that okay? Obviously, there are sort of like other causes which first degree heart block, and which is normal in some children, or atrioventricular block and the complete heart block. But when you come across these, the child will be fine, and you need to get an opinion from a cardiologist what to do with them. Is that all right, guys? Any question before I move to the other sort of set of ECGs? Yeah. Are you happy with the bradycardias and the asystole and the PEA? Well, haven't got a response so far, so perhaps I should move on. Guys, talk to me. I'm in my room on my own. So if you say yes, Laura, thank you very much. Yeah, I move on. Okay, and then we go to this sort of like we talked about the management. So this will be the tachycardia. The tachycardia, I put them on one slide again to show you the difference. This one, the first one, is just like supraventricular. This is the sinus. Sorry, this is sinus tachycardia, right? And this is supraventricular tachycardia. This is SVT. Yeah. Any difference between the two? Quickly, if you know any difference between these two, they look similar, but there is one bit which like gives you the clue why this is like sinus tachycardia, which can happen. Yeah, P waves. Safe joined us. Hi, Safe. Right, thank you very much for that. Right, yes, the sinus tachycardia happens if the child is anxious, if the child is like in pain, have a temperature, or a bit dehydrated. But you can see the P wave here before every QRS complex. Here there is no P wave, right? And obviously the rate here, this is 150, yeah? Can you see that, right? But here is like 200 something, yeah? This is like 300, 280 or something like this. It's just one small square and a bit. So it is like very, very fast, this one. And then this is bizarre and this is bizarre. This could be easily ventricular tachycardia or VF. Both of them are just ventricular sort of rhythm. They are wide and irregular sort of waves. And this is what you need actually in emergency. You don't have to like be very specific about this and that. Okay, either they are fast and narrow with a P wave or not, or wide and bizarre, yeah? And this is how you quickly get into the management. For the SVT, you'll find a child, which is supraventricular tachycardia, obviously. You find a child who is stable and good, but he is a bit disturbed because he feels his heart, which is not a good feeling, actually. If you are sitting without exercise and you find your heart racing, and then you the child is clinically stable, is not shocked or anything, then you ask them to do Valsalva's maneuver as if they are like sitting in the toilet and trying to poo, and or you unilaterally do the carotid massage or put ice on their face. But if this is to buy time until you prepare the adenosine, and the adenosine you have to inject it in very quickly, and in a vein which is nearer to the heart. And then if you look at the screen, you would be shocked that after the very racing sort of heart, he found a flat line and said, oh my God, I killed the child. No, you did not kill the child. What happened is like the heart stopped because of the action of the adenosine and then regain the sinus rhythm, and this would be a relief to everyone. And then if the smaller dose doesn't work, then double the dose and then the child will respond. If the child is unstable, then this is where you put him as the APLS chart in the synchronized cardioversion. Synchronized. So you have to be sure that it is synchronized, right? Synchronized means that you see a dot over each R wave on the screen. If you give it in unsynchronized, this will be a disaster. You'll get him to VF, yeah? So 1 joule per kg, and then repeat 2 joule per kg if no response. And adenosine, give adenosine until you set up the cardioversion. Is that right, guys? So the key word here is synchronized, right? The VF, as I said, like wide and broad and bizarre, and the rest of it will not, like, you will not calculate the QT in an emergency situation, but you will think of the management of the VT. I have this in front of me, what I'm supposed to do for that sake. And as Vicky and Laura and the rest of you, Charlotte and Saif, are thinking ABC, right? Always start with the A. Always start with the A. If you jump on the B or the C while the airway is obstructed, or if you are not giving good oxygenation, you are wasting your time and the patient's time. Obviously, if they're shocked, you will ventilate them. And if they are stable with a pulse, you can try magnesium sulfate, give amidrone, lignocaine. And if they are unstable, but again with pulse, then you give synchronized shock, synchronized cardioversion. Yeah, this is similar to the SVT, isn't it? And add amidrone if there is no response. If it is pulseless VT, pulseless VT means a dead child, guys. Yeah, pulseless VT means follow the VF protocol, which we showed in the APLS algorithm. They are dead. So you follow the protocol as it is there. Let me find out. I haven't put it on again. Okay, let me see. Okay, this is the one. So this is the one which is on the left side, the shockable, and you go through this line. Yeah, let me go and see whether you have written anything. Okay, any question, guys, about this scenario? A child who presents to the emergency department with abnormal rhythm, with shocked, basically. Yeah. Any question about this? If you say no, all good. Thank you, Laura. I'll move on then, and then we will move into this scenario where we have this child who basically road traffic accident. 6 years, ran out of the playground into the road in front of a car. The car swerved, but still hit him, and he was rushed to the hospital by ambulance with C-spine embolization. There is blood oozing from his right ear, and his right lower leg looks deformed and discolored. Noisy breathing. Listen to this. He has noisy breathing. Important, this noisy breathing, yeah? This means, let me see whether you know what noisy breathing means quickly. What does this noisy breathing mean in this scenario, guys? Noisy breathing. No? I got a message here. Where is the message? Yeah, Stephen, about airway obstruction and the cerebral angiohematoma. Okay, yes, he has some injury, and he is going into coma, and this is the upper way obstruction because the way he is sitting, the tongue went down there, and he can't breathe. Right? Obviously, respiratory 26, so he's breathing, but the tongue is sitting down deep in his mouth and noisy breathing. You have to adjust his airway to open his. The capillary fill time is 3 seconds. Blood pressure lowish side, and the FPO P like pain, which like right. The right pupil is dilated. Obviously, it would be like stupid if I say good or bad because it looks very, very bad. But where would you start? Where would you start in a scenario like this? Again, I need response. Where would you start? So many injuries and so many like pathologies. Where would you start, guys? Anything? I got A, B, C, D, E, and once stable head CT scan, and I got airway adjunct spine protection. All good, all good. Well done, guys. I hope I'm talking to FI too, not like accident emergency specialist there. You are giving me all the right answers. Perhaps you come and take over them. Well done, guys. The airway here is crucial because if we manage anything before giving attention to the airway, this would be a disaster. Okay, as you are saying, airway and C-spine, and if in doubt, assume neck unstable, that's fine. Give oxygen, intubation. The intubation here is because of the FPO of P, and this P, which is response to pain, means that the GCS is less than 8. And if this is what you get, either GCS less than 8 or P, don't think of anything. You just go ahead and intubate, right? There's no negotiation here. Obviously, we talked about the nasal intubation, which is contraindicated here. And you do all the measures here, like your aim. Obviously, this child during the injury, he sustained some brain injury, right? So we can't do anything about this. But what we can do is to prevent further brain insult, further brain injury. And this is, if to prevent it, you have to keep this child very well oxygenated and his fluid balance and the blood pressure normalized. Yeah. And once you stop the hypoxia, once you stop the hypotension, life will be rosy. Whatever damage has happened has happened. You can't stop it, but you prevent further damage. Further damage means you reduce the intracranial pressure because with the head injury, blood and edema of the brain and all that stuff, so the blood, the intracranial pressure is high. And in the old days, we used to do funny things with like, get this PSU2 at this level and that level, and or hyperventilate and mostly all turned to be rubbish. Basically, get things normalized. Normalize the temperature, the blood pressure, the blood gas, and I wrote BG twice. So one of them blood gas. What is the other one, guys? Quickly. Quickly. I wrote BG twice. One is blood gas, normalized blood gas, and the other one, shall I move on? Shall I say it? The blood gas and the blood glucose. Oh, well done. Yes, safe. Well done. Blood glucose. Yes, the blood glucose, guys, don't ever forget blood glucose. Yes, so normalize the blood glucose. Give morphine for the pain. Uh, Stop the seizure if it happens. Electrolytes, you have to correct them. 3% saline. 3% saline now is more popular than the mannitol. I haven't used mannitol for ages, but if you don't have 3% saline, actually it's 2.7% saline, but we call it 3 saline, 3% because it's easier. So use mannitol. And then the CT scan, as you guys said, and the CT scan will tell you uh, where you would like to open the skull and evacuate the mass and do the drainage, right? And this is what you get, yeah? So this is acute subdural hematomas with a mass effect. Obviously, the brains here, bless them, they are very squashed to one side. So you have to do something very quickly here, right? So these are the subdurals, and this is how it look. And this is the extradural, yeah? And again, mass effect, right? So you have to do something. You can't just sit on this child and they say, okay, let us wait and this is absorbed. No, anything with mass effect, shifting the brain to one side is bad. And so this is like, it is, these two scenarios are time critical. So get them out of the hospital, get them to the neurosurgeon. And also, if you see this one, yeah, very bad, hydro, hydrocephalus, isn't it? This is like very, very dilated ventricles. Yeah. So this is bad as well. Yeah. You need to, because this is like obstruction somewhere, right? It's likely to be in the fourth ventricle to give you very dilated ventricles. And this slide just to tell you how quickly the intracranial pressure increase and the GCS drops from 15, 12, and then 3 with the slightest increase in the intracranial pressure. Raise the intracranial pressure, right? You can pick it up clinically, yeah? The first one is fluctuation in the state of consciousness. And this is like, guys, clinically, and even from the history. If a mother come, I'm not talking about like imaginary sort of scenario. We have seen this. Child who comes and the mother says, guys, my child is sleepy and not well. And you examine that child and that child is like sitting bolt upright and playing with you, right? Don't ignore the mother's talk, because this what we mean by fluctuation of the state of consciousness. Child is 1 minute good, other minute is sleeping. For your information, if you don't know this, children are always on the go, right? They want to play, they need fun. If they are sleepy during the time or not, they are not sleeping, it's not sleeping time, you know that there is something wrong with this child. So fluctuation of the state of consciousness, you have to take it seriously. Obviously, deteriorating loss of consciousness, this will be in front of your eyes. You will use the F2 and the GCS. Normal or high blood pressure in a child in this trauma scenario will be one sign of raised intracranial pressure. Inappropriate slowly or normal heart rate. Again, because the child here is like has lost blood and increased intracranial pressure, so you expected the heart rate to be higher because of the pain and all stuff. So if you find normal heart rate, no, this doesn't make sense. Yeah. So the heart rate is supposed to be high, but it's normal. No, so this is like bad. And decrease the capillary fill, obviously, this is like well known. And the others is like unequal or dilated reacting pupils, obviously this is bad. and the rest are quite obvious or like self-explanatory. But the first few, like the fluctuating state of consciousness or the deterioration of loss of state of consciousness or normal high blood pressure, the heart rate, the capillary filter. So unequally dilated, poorly reacting pupils, abnormal respiratory pattern, focal neurology, abnormal posture and seizure, all these tells you that there is something wrong with the pressure inside this head. All of us, I've been in this job for like a long time now, if you don't know me, but all of us are obsessed with this Cushing triad because we read about it and we always ask about it, decrease of self-consciousness, hypertension, and the bradycardia. If you wait until you see this, this is likely to be late because this means the brain is herniating. So this means that by the time he goes into theater, he's gone. Yeah. So do all your best to stop these signs happening to the child, and the best is to get this child, stabilize the child quickly and get him out of the accident. Any question about this scenario, guys? I'm trying to get any question. If you say no, I will move, but I need to see no before I move. Yeah. So this is a scenario, trauma scenario. Thank you, Vic and Delora. No. Okay, everything is going all right. Just move on. Okay, I'll move on then. Right, why I can't move on then? Oh, something happened here. Yeah. Okay. Yeah. Yeah. So this is another child actually, but I need to know the diagnosis from you before I move. I'm not going to move on until you write something about this. This is a child who the GP referred, 7-year-old boy, breathing faster than he should, and 3 days non-specifically unwell, and recent wetting bed. So 7 years old wetting the bed. Is it good or bad? And what do you think about this? What comes to your mind when you hear this scenario? Anything? Do you like send him to the enuresis clinic or bedwetting clinic? Because 7 years old, like he okay, bedwetting. Any calls? Doesn't have to be right or wrong cause. You just say anything which comes to mind. You are in the hospital. UTI, safe say UTI. Any other bets? Okay, I will take Vicky's UTI and safe UTI and move on. Okay, the trick here is obviously the child of 7 does not wet himself or herself, and he's breathing faster. Breathing faster might come to you as the child has a breathing problem. There is a difference between a child who is breathing fast because of a breathing problem, which is basically lung, sick lung, and a child who is breathing faster because of something else, like, for example, acidosis, right? Whether it is diabetic acidosis or renal failure acidosis, or ingestion of high dose of salicylate acidosis, or ingestion of coolant at home. All this gives you acidosis. The difference between the lung pathology and the non-lung pathology is the intercostal retraction. So if you see a child who is 7 and breathing faster, and you want to know whether this is lung or not lung, look at his recessions. If he is recessing, this child has lung pathology. If he's not recessing, this child has acidosis. Yeah? And then the bedwetting, they usually don't wet their bed. And This is why I'm thinking it differently. But the rest of the information is like temperature, okay, pulse a bit on the high side, respiratory rate, we said he's breathing faster, and it is deep. Our normal respiration, if you think about it, is not deep. So when it is deep, this means like deep acidosis. This is acidosis, sorry. Saturation is fine. Capillary fill is a bit dehydrated. Food blood count, he has white cells high and neutrophils high, which goes infection. CRP is 30. Yes, he has infection. Sodium is low, doesn't go with UTI. Urea is high, yes, because he had dehydrated. Creatinine is again high, yes, dehydrated. But the blood sugar here, 32. And the glucose and the ketones are high. So put this all together and you'll find yourself dealing with the diabetic ketoacidosis. Yeah? And some children are brought because of wetting their bed and referred to the neuresis clinic, and they are living with diabetes. So any child who wets his bed, right, after being dry, you have to rule out diabetes. Yeah, obviously the child did not have infection, but this is the picture of diabetic ketoacidosis in a child. Is that all right, guys? Yeah. Then quite obvious that this is like acidosis, severe acidosis. When he presented on day one, the pH was 6.93. Yeah, and repeated getting worse. Yeah. So the reason I'm saying this diabetic ketoacidosis is because he has acidosis. Yes, the bicarbonate 15 millimole or pH less than 7.3, and the ketones more 3 millimole. So by definition, this is the nice guidelines definition of diabetic ketoacidosis in its children, and they classify them into like three sort of categories: mild, moderate, severe. The mild, this is based on the pH and the bicarbonate. If the pH is 7.2 to 7.29, or carbohydrate is less than 15 millimole per liter, this is like mild, and the dehydration is 5%. If it is moderate, it will be pH 7.1 to 7.19, or bicarbonate less than 10 millimole per liter, and this is when you say, okay, perhaps the dehydration here is 7%. And when it is severe, like the pH is less than 7.1, serum bicarbonate less than 5 millimole, then you say, okay, perhaps this dehydration is 10%. And here in the South Thames, we have two guidelines. One is the British Society Pediatric Endocrinology and Diabetes Interim Guidelines, which is 2020 updated, and the STRS. The difference, you can use either of them, and the difference between the two is that the PSPD guidelines now are using liberal fluids, while the STRS are using less fluids. Less fluids or more fluids, the PSPD like initially was on liberal fluids, and then in 2015 went into less fluids, and then 2020 they went back into the old liberal fluids, and but the STRS consistently went into like less fluids. But if you use this protocol, that's fine. If you use this protocol, that's fine. And it's not that scary. Once you see a child who has diabetic ketoacidosis, basically what they need, if they are shocked, and there's another issue here, or changed the guidelines that we now work towards improving the capillary fill time, when in the past we ignored this. So the principle is easy. You don't have to worry much about if you have a child who has diabetic acidosis and say, oh, what I'm supposed to do. The ABC you will follow, but if the child is shocked, i.e. tachycardia, and prolonged capillary refill time. Then treat the shock, 20 mils per kg, another 20 mils per kg, and then then you can give anatropes. And then if you put him on slow rehydration over 48 hours, and then you can start the insulin after an hour, right? So you have plenty of time even to have a cup of coffee until the fluids run. Obviously, you will not leave him and go have a cup of coffee, but it means that once you start the fluids, you have done a good job. And then the insulin can start later. And then you keep monitoring the potassium, the glucose, and the blood gas, and the other electrolytes. And you need to keep an eye on him in the first, especially in the first 24 hours, to pick up signs of cerebral edema. I'm not going to go into signs of cerebral edema because they are the same like the signs we mentioned in the head injury, where there is like increase in the intracranial pressure. If you notice any of these, then give him urgent dose of like 3% saline. Yeah, and you carry on the monitoring. And this is like summary of the treatment of diabetic ketoacidosis. And if you have any question, it's time now. Guys, am I supposed to finish at 2 or should I carry on? Because there is another scenario and I don't want to, yeah.
Please carry on, Dr. Mansy.
Yeah, thank you. Any question about the diabetic ketoacidosis, guys? If you say no, I'll be okay that you are around still and you want me to carry on. Just a hint. Yeah, no. Okay, thanks, Laura. Okay, I'll move on then. Yeah, this is another scary scenario, which when it happens again, remember the child you saw in the first, at the beginning of the presentation. But this is clear, right? 6 years old girl brought into the emergency department with prolonged seizure. Yeah, we now use prolonged seizure. We said to use status epilepticus. She's a non-epileptic anyway. Yeah, and has started feeding at home and has already received the 5 milligram of rectal diazepam. And she's still feeding and has no IV access. So the rectal diazepam at home hasn't worked. And when the child comes obviously to the hospital, this will be again A, B, C, D, E. And this is like when they call you for a child who is seizing. You always think why the child is seizing. It doesn't matter, right? Just to go and sort out the seizing, and then we'll find out why he is seizing as we go along. And we start with the A, so give oxygen, keep the airway opened, don't put your hand in here or your fingers inside his mouth, and then check the blood glucose. This is very, very important. Now, if you think of that A, B, C, D, E, F, G, you find the G is like the bottom of this like alphabet. But in a situation like this, if you go and know that seizing a child who is epileptic, who is like on medicines, he shouldn't feed unless he missed a dose or he has a diarrhea and the vomiting, and every dose he takes it, he vomits it, so it's not working. And think about the glucose. Once you pick up the hypoglycemia and you give him like 2 mils per kg of dextrose 10%, the fits stop. So you don't have to go through the rest of the scenario. But if you miss this part, right, of the check the glucose at the beginning, and you carry on giving him, give him midazolam, give have a line, give lorazepam, not stopping, then give him another lorazepam. All these will like decrease, will press his respiratory center, and then he will stop breathing, and you put intubate him and all the stuff. Yeah. So if the blood sugar is fine, great. Then go and give midazolam. If it doesn't work, or he gets, you get the IV line, give lorazepam. If it doesn't work, lorazepam. But here you have to look for apnea. Yeah, because the child got a dose at home, and you give him midazolam, and when there is a line, you give him lorazepam, he can easily go apneic here, right? If not apneic, it's not still fitting, then you give phenytoin. If he's already on phenytoin, perhaps it would be better to give him phenobarbital. And if this does not work, so then you have no option but to call the anesthetist to do the rapid sequence induction and intubation. But if you look at like the time here, like from 0 to 5 minutes, and then from 5 minutes to 15, this 10 minutes, and then 15 to 20, every 10 minutes you change something. But the last one after the phenobarbital is like is 20 minutes. This is to give them like time for this IV phenytoin to work. So it's a long time when you are dealing with a child with seizure. And if you can pick up the diagnosis, this will be fine. Like, for example, if he's already fitting and on medications, so it's likely that he has missed a few doses, or has been vomiting, and this is why he's not getting, or has diarrhea, and this is why the medicines are not working, or he has started new medicine for any other reason which affects the medicine, the bioavailability of the medicine he's already on, or if he has completely different reason for him to have status epilepticus, like for example head injury, or there is new brain pathology like trauma or the like. So in the situation like this, you might consider a CT scan or MRI. Obviously, you'll communicate with his managing consultant, but you have to think laterally, like not just epileptic. Yeah, they can get this and give him the medication, send, observe him and send him home. There might be another, so it needs dig deep stuff, but this is not your job in the emergency department. Obviously, if you pick it, that's fine, but this job would be to the pediatric team and the pediatric ward. So the CT scan and the MRI is all this on the table. I have gone through a lot of scenarios, and you have been marvelous answering the question and giving me energy to move on. I will stop here, and I'm happy to take any question, guys. Well, this is silence, which can work two ways, but I'll take it on the good way that you are. Could you use Kepra in this scenario? Well, this is a very good question. Kepra is coming in the guidelines, but it hasn't appeared officially yet. But yes, if you communicate with the treating consultant and they have consider this, yes. But so far we are following the APLS guidelines of as in the algorithm I have shown you in the slides. But yes, I can see that people now are talking more about Kepra IV to treat the status epilepticus. Yeah, obviously I haven't touched. Oh yeah, thank you, Laura. I haven't touched on obviously other sorts of convulsion as children, but we have obviously from 6 months to 3 years they can present with febrile seizure, and when they present with febrile seizures and it is prolonged febrile seizure, then you don't send this child home. You keep him in house and try to rule out meningoencephalitis. Yes, I got a thank you from Laura. If I get another thank you, then I will say goodbye. And yeah, hopefully uh, you'll join us pediatrics at some stage and then live the experience. Okay, bye, Fiza. Goodbye, guys.
Thank you very much, Dr. Mansy. We will see you at the RCP panel.
Yes, I will in June. Yeah.
Yes, pretty much nearly there. Yeah, in 2 months' time. Yes.
Time flies. Thanks, Mina.
Thank you very much.
Bye.
Bye, guys. FY2s, please let me know or send me a message if there is more than one of you in the group. Thank you.